This is the first KDIGO guideline on diabetes and chronic kidney disease management. Comes at a very opportune time with an increasing prevalence of diabetes and chronic kidney disease and new technologies and therapies available for treatment. This guideline has been approximately 2 years in the making, including evidence and synthesis and review, and we anticipate that the full guideline will be published this summer. So this webinar is really a sneak peek into what will be coming out as a brand new guideline for revising clinical practice. This session was originally scheduled as a presentation during the World Congress of Nephrology, which was canceled due to COVID, and the presentation was rescheduled to today. This presentation was made possible through a collaboration of International Society of Nephrology with Boehringer, Ingelheim, and Lilly. And we're pleased to present an overview of the guideline today. Okay. These are my disclosures. I've consulted for Boehringer Ingelheim, George Clinical, Goldfinch Bio, and Ironwood. And I'll give a brief overview of the goals and methods of the guideline before I pass to our speakers. Broadly, these are the goals that the work group had in creating the new KDIGO guideline. We wanted to generate a useful resource for clinicians and patients, addressing relevant questions with actionable recommendations, taking on controversial topics when there was sufficient evidence, and communicating clearly by highlighting recommendations with figures and tables. We aimed to be very evidence-based, staying true to the evidence, high-quality evidence available, focusing on randomized clinical trials, and targeting a broad audience, primary clinicians treating diabetes and chronic kidney disease. We were mindful of implications for policy and payment, and we proposed research questions when there was a need for more data. The scope of the clinical practice includes types 1 and clinical practice guideline includes types 1 and 2 diabetes, all stages of chronic kidney disease, including kidney transplant recipients and patients treated with dialysis. We assessed interventions of all types addressed with rigorous data, focusing again on randomized clinical trials. These include lifestyle therapies, pharmacotherapies, and systems approach to managing patients with diabetes and chronic kidney disease. There are important aspects of care in this field that we did not cover in this particular guideline, including blood pressure management and lipid management, which are addressed by separate KDIGO guidelines. Prevention and screening, which are absolutely critical to identify the population of people with diabetes and chronic kidney disease for treatment, but considered out of the scope of this treatment-focused guideline. And there are many topics that are important and emerging for which there was insufficient data to make firm evidence-based recommendations, including diagnosis of diabetic kidney disease and emerging and pipeline therapies that do not yet have adequately powered phase 3 clinical trials to make solid recommendations. The work group was the guideline was generated by a diverse work group listed here. There was diverse expertise, including nephrology, endocrinology, pharmacology, internal medicine, cardiology, nutrition, and very importantly, 2 patients who were part of the working group from the very onset, helping frame the questions to be addressed and the manner in which the evidence was synthesized. There was worldwide representation, deep experience in all these fields, and the guideline was supported by an expert evidence review team. The evidence review team was the Cochrane Kidney and Transplant Group based in Australia. They reviewed thousands of articles focusing on randomized controlled trials, but also including observational data and evaluating that data using the GRADE approach. The guideline has 5 chapters organized as you see here, including comprehensive care in patients with diabetes and chronic kidney disease, glycemic monitoring and targets, lifestyle interventions, anti-hyperglycemic therapies, and approaches from systems and self-management approaches to patients with diabetes and chronic kidney disease. And we'll touch on all of these throughout the course of this webinar. So without further ado, I'll note that we have 3 speakers today: Tammy Sadowski, Peter Rossing, and Kathy Tuttle. And I'll introduce each as they start their presentations. So first is Tammy Sadowski. Tammy worked for 22 years as Executive Director of Research, Finance, and Operations at the University of Washington here in Seattle. And she is a patient who has diabetes and kidney disease. She is also now an active volunteer in the area of research and transplant care. She will speak to her experience as a patient living with diabetes and chronic kidney disease, how that framed her approach to the working group, and that in turn helped frame the working group's approach to the guideline. Tammy?
Thank you, Ian. Yes, I'm Tammy, and I'm very glad to join you today. So when I was first asked to participate on the KDIGO Guideline Working Group, my first thought was, well, this is fabulous. You know, what a great idea to incorporate the voice of a patient in the group. It's fairly rare to have the opportunity to be a part of a group developing guidelines about your own care. And I just want to thank KDIGO for stepping into this arena and potentially changing the course of making decisions about patient care in the future by really asking the patient, what do you think? So the patient voice, I think, brings a new and different perspective to the table. What I found working with this group is that the facts and the research are key to the guideline development, which is how it should be. But then bringing in the real life of a patient into the conversation helps validate things even more. You can tell a patient, and I'm speaking from experience, you can tell a patient 10 times to take a certain medication, eat this, don't eat that, exercise more, take less insulin. But if they become so overwhelmed and are not able to handle everything, then all these great recommendations become, well, not very useful. Guilt is a huge issue for patients with diabetes and CKD, and really understanding how to help them manage all they need to do is so valuable. So again, having a patient voice in the room when developing these guidelines can be extremely helpful for the physicians around the table and the patients. So my experience working on this team, what a unique experience I have had. How often is a patient able to sit in a room full of physicians, describing to them how a certain medication impacts their daily life, or how a lower or higher A1c would help them, or explain how hypoglycemia is so difficult to deal with. I've been involved with many groups and teams and councils over the years, but never with a group so passionate about their work. I could tell everyone on this working group really cared about their patients and how the decisions they each made will assist in determining their patient's health. As I've mentioned to some of the group, I would feel very fortunate to have any of them as my endocrinologist or my nephrologist or my cardiologist. The other thing I found so valuable was the experience of creating guidelines for people all over the world. I was naive going into this, but I quickly learned that every culture is so very different, and the needs of a person with diabetes and CKD in one country can be profoundly different from other countries. And although there are similarities, of course, the guidelines really had to take into consideration many components, including cultures and cost. The availability of the medications was a huge issue, and family dynamics. So I'm going to switch gears a little bit here and tell you about myself and my life living with diabetes and CKD and where I am today. I was diagnosed with type 1 diabetes at the age of 13, which, as you all know, in general is a difficult time entering puberty. Then you add diabetes on top of that, and you have a whole new life you really are not so sure you want, but you have no choice. I began with 1 insulin shot a day, NPH, was told not to eat sugar, to follow a low-carb diet higher in fats and proteins, to come in for a glucose test once a month, but otherwise life as usual. My siblings by that time were off to college, so my parents and I made our ways through this diabetes maze, trying not to make too many mistakes. And what a maze it was. We had limited health care available. My family lived in a small town in Alaska with one doctor, one small hospital. And although I was diagnosed after about 10 days of exhibiting symptoms, the management plan was quite limited, but it was based on what was known in that area at the time. Today, I feel one of the most important things for individuals is to be tested and diagnosed early and to begin a sound care plan immediately where the patient, their family, the physician, and other healthcare providers are working as a team. Education at this point is so very important. And quite honestly, at this point, the patient doesn't even know what to ask. It is not true that what you don't know can't hurt you. Quite the opposite. So when I was diagnosed, we were given the basics of how to manage my diabetes, but discussions of how to really ensure that I stayed in good working order and what things may happen down the road if I wasn't, they weren't really discussed very much until those things, also called complications, started happening. So as I mentioned, I started on one insulin shot a day, which over the next 20 years increased to 4 shots a day. A1c was not available at that time, so monitoring my glucose level was really a blood draw at the hospital about once a month. If the level was around 100, then I was told, oh, you're doing great. Keep on doing whatever you're doing. Doing great. If it was around 400 or so, then I was told, well, you're not doing so great, and why are you not doing so great, and what are you doing wrong? Guilty again that I was messing things up, but I wasn't even sure why. So I started going into these trance-like states, fainting occasionally, shaking, as my glucose levels plummeted, often with hypoglycemia, and that became the norm as we tried to balance my glucose levels. So lifestyle factors were rarely addressed then. It was not a big consideration when I was first diagnosed with diabetes. You were given the rules, focused on insulin, eating, some exercise, but how to make everything work well together so I would feel good every day, that I didn't have these ups and downs, that I would be mentally sharp and avoid future complications, that wasn't high on the list. As I later learned, they must all work together for the body to really work well with diabetes. I'm sure it's no surprise to any of you that I developed some serious complications within this time period. For 20 years, I lived with type 1 diabetes. I lived with it, I battled it, my parents battled it. We hoped for the best and prepared for the worst. So first I developed retinopathy, having cataract surgery at the age of 21, laser surgery over 20 times to cauterize the blood vessels that were leaking in my eyes, partial loss of vision in one eye, and complete loss of peripheral vision. Neuropathy arrived right around the same time. My hands and feet were tingling, numb, cold all the time, pins and needles sensation that just would kind of attack my chest, and I could feel it all over my body were pretty constant for a while. And then gastroparesis came. I would wake up on the sidewalk after passing out, surrounded by paramedics, or on the floor of a shopping mall, a grocery store, a bank, didn't matter where. But by this time in my life, the insulin I was injecting was not really assimilating with the food I was eating, nor the exercise I was participating in. So when the insulin kicked in, but the food didn't, my glucose dropped significantly and down I went, out again, unconscious, until the paramedics arrived. I also began carrying bags around with me because gastroparesis also included vomiting, which I did practically every day for a while. Then finally, no surprise, I was told my kidneys were failing. But otherwise, life moved right along. I attended college, I received my master's degree, and I worked full time. But then my life changed. Next phase, transplant. Excuse me. So after receiving news that my kidneys were failing and that I would probably not live through another blackout with gastroparesis like the one I'd woken up in bed paralyzed, unable to reach the juice and sugar next to my bed, unable to make words, only sounds. After that incident, where I was lucky enough to be found by some paramedics, I was put on the waiting list for a new pancreas and kidney. 2 months later, life phase 2 began, and it looked pretty darn wonderful. No glucose monitoring, but a whole new list of medications. So the last time I took my glucose level or used insulin was the day before my transplant. My father brought me 3 candy bars on day 1 post-transplant, even though I was still hooked up to numerous tubes and couldn't eat a thing, but he was so excited for me. Time moved quickly, 9 years and 9 days in the hospital. 6 months later, I began working full-time. I began walking, walked half marathons, I took up ballroom dancing and golf, traveled internationally, and I lived. I just really, really lived because I felt so good. But I knew that the immunosuppressive medications that I would take daily for the rest of my life may have long-term side effects. But for years, I was doing pretty good. You know, people often tell me that I don't look like I've had a transplant, which always confuses me. Should I look tired and unwell and haggard? No, I should look healthy, right? Which I credit to really focusing on a couple of key elements post-transplant. My diet, and although I was now able to eat sugar-laden cupcakes and jelly beans, and I did, of course, but in moderation, just now and then, and exercise, which I amped up during my recovery, really helped me not only enjoy my new life, but ensure that I was doing everything I could to take care of my new organs and to keep them with me as long as possible. Unlike after my diabetes diagnosis, I had a full healthcare team to work with post-transplant. It made all the difference and still does today. And although I parted ways with my wonderful endocrinologist as my primary physician, I stayed in touch with him as I worked with my new nephrologist and other healthcare providers to really monitor my new organs and stay on top of any transplant-related issues that would come up. And for 15 years, pancreas and kidney ran very smoothly as I packed as much as I possibly could into life. Sadly, after years of reoccurring UTIs, it was decided a new kidney might be better than spending as much time that I was in the ICU for a couple of years. In 2011, my second kidney transplant was a success and is with me today. So 2020, this year, I have 27 years with my pancreas and 9 years with my second kidney. Beyond transplant. I'll be brief here. We want to get on to the guidelines, but I just want to say that my life changed really 100% for the better after my transplant. I worked at the University of Washington for 22 years, leaving only to pursue my goal of giving back. And in the second part of my life, to really give back to the diabetes and transplant and kidney community that has played such a huge role in my life. I really would not change a thing that has happened in the past. It made me me. Although I know that I may be faced with some serious challenges ahead. But diabetes, as you all know, is a very serious disease and impacts your entire life, as does CKD, as does an organ transplant. We all must deal with what we have been given, and we do that in different ways. As a person with diabetes and CKD, I was susceptible to many other medical issues and experienced a number of them. As a transplant recipient, I am more susceptible to things like cancer, osteoporosis, and there is a chance I will lose one or both of my organs new organs, resulting in diabetes and or CKD again. I try not to focus on these things, but of course they do concern me. My dad, who at the age of 94 today, has always told me that moderation is the key to a healthy life. I think he's right. I'm well versed in things that will keep my organs and me healthy, like eating well, exercise, taking my transplant medications on time every day, and just doing common sense things like washing your hands on a regular basis. So as I turn this over to Peter and Kathy to review the new guidelines, I'd like to reiterate just a few things that I've already covered. These are from a patient's perspective that can lead to a really great working relationship with their physicians and healthcare teams. And of course, the importance of early testing and diagnosis is critical. And including the patient in the decision-making process for their care and really encourage that from the beginning. Some patients may be a little reluctant, but I think as they become more involved, they realize that it is important to be a part of the decisions in their care. Ensuring that a healthy lifestyle is in the decision-making process to reduce future complications. That's absolutely important in considering each person's lifestyle, everything from a diet. Someone may want a vegetarian diet or different work schedules or different exercise schedules. Ensuring healthy lifestyle is a priority with healthcare individualized to each patient. And finally, so valuable and so important is a need for a team-based approach to healthcare and patient care. Thank you for listening, and now on to the guidelines.
So next, I'd like to introduce Peter Rossing, who is Professor of Endocrinology and the Head of Complications Research at the Steno Diabetes Center in Copenhagen. He's an active researcher in the area of diabetes and kidney disease, and of course was co-chair of this guideline. And Peter will be talking about the management of diabetes and chronic kidney disease. Peter? While Peter's getting his audio and visual turned on, I'll note that Peter and Kathy Tuttle, who perhaps I'll also take the time to introduce, will be splitting an overview of the guideline. It won't proceed chronologically by chapter, but instead will integrate the chapters first with the diabetes monitoring and treatment approach, and then focusing specifically on drugs for kidney protection. They've divided up the key messages from the guideline. Peter, are you available yet? All right. To save time when we get to Kathy's presentation, I'll introduce Kathy now so that we can go straight from Peter to Kathy. Kathy Tuttle is the Executive Director for Research at Providence Healthcare in Spokane, Washington. She's also a Professor of Medicine at the University of Washington here in Seattle, where I am as well. She is uniquely trained both in nephrology and endocrinology, perfectly poised to bridge those two disciplines as we've done for this guideline. And after Peter concludes his talk, she'll be talking about the management of CKD and diabetes.
Okay, thank you very much. Sorry for this. Thank you for the introduction. And as you said, I'll talk about the diabetes management. First, these are my disclosures. I've served as a consultant and educator for different companies, including Boehringer Ingelheim and Eli Lilly, and had research grants from AbbVie, AstraZeneca, and Novo Nordisk. Now, the outline of the guideline, as you said, Ian, is a chapter on comprehensive care, glycemic monitoring and targets, lifestyle intervention in patients with diabetes, anti-hyperglycemic therapies, and approaches to management of patients with diabetes and chronic kidney disease. And I'll take part of this, and then Kathy will continue with the remaining issues. First of all, as in any patient with diabetes, whether there's chronic kidney disease or not, it's important with glycemic control. Immediately there's the symptoms of hyperglycemia or hypoglycemia, which are important to avoid. And there's also on the long term risk of late complications, as we just heard about from Tammy, where it's from several studies like DCCT in type 1 diabetes and UK-PDS in type 2 diabetes demonstrated that if you improve glycemic control, you can reduce the risk of these microvascular complications. Whereas the benefit on macrovascular complications has been a little bit more complicated to demonstrate in intervention trials, whereas there is an epidemiological association between high glucose and high risk of cardiovascular disease. And then, of course, you can say that when we optimize glycemic control with intervention, there's an immediate benefit on some of the symptoms of hyperglycemia, whereas there's long-term benefits to be gained on microvascular complications, but there are also acute side effects potentially of hypoglycemia if treatment is too intense. To provide you with some of the data that are from the evidence review in the guideline on microvascular complications, this is a review of the progression on microalbuminuria, where you can see a reduction in the risk for progression from micro to macroalbuminuria if you improve glycemic control. If we take the later stages of chronic kidney disease, end-stage kidney disease, there are not that many data demonstrating a benefit of glycemic control, but these are data from the advanced trial, large trial with more than 10,000 individuals with type 2 diabetes, where intensive glycemic control reduced end-stage kidney disease in these patients. However, only very few, less than 30 patients, develop end-stage kidney disease. So data for this is limited, but again suggests that improving glycemic control has an impact on long-term outcome. As mentioned, if we go to the cardiovascular complications, it has been more difficult to establish that intervention can reduce cardiovascular outcome. But in the guideline, we have this meta-analysis suggesting that there might be a benefit of tight glycemic control on myocardial infarction in diabetes with chronic kidney disease. As you can see, 18% risk reduction, which is just significant in this meta-analysis. So this is the evidence that treating glycemia can delay both the micro and macrovascular complications in patients with diabetes and chronic kidney disease. But how should we monitor glycemia in patients with diabetes and chronic kidney disease? That has for a long time been a matter of debate. In general, we use in diabetes hemoglobin A1c or glycated hemoglobin as a measure of long-term glycemia. We heard Tammy discuss glucose measurements once a month, but obviously a glucose monitoring is just a snapshot of what's going on, whereas hemoglobin A1c provides an approximate 2 months average of the glucose value in diabetes care. But as you probably also know, in chronic kidney disease, using hemoglobin A1c has some drawbacks, and therefore alternatives like glycated albumin, fructosamine, and hydroglucitol has been suggested as alternatives. This table is just to summarize some of the benefits and drawbacks, and to focus on hemoglobin A1c. That's what we use in general for monitoring long-term glycemia in diabetes. But in chronic kidney disease, because of increased red blood cell turnover, there is a problem where the association between mean glucose and hemoglobin A1c may be impacted. Glycated albumin, fructosamine, and 1,5 and hydroglucitol doesn't have this problem with red cell turnover. They are slightly short-term markers giving an evaluation of glucose for 2 to 4 weeks period, but they may also be impacted by chronic kidney disease, particularly in cases with severe proteinuria. They may be affected. And also there has been problems with the standardization of these different methods. So translating values into mean glucose values has been complicated. We have recommended in the guideline to use hemoglobin A1c also in patients with chronic kidney disease, because studies have demonstrated an association which is good to fairly good between hemoglobin A1c and average glucose values or fasting glucose values, and also continuous glucose monitoring, at least and particularly in patients with a GFR above 30. It has been looked upon the association between the different markers and mean glucose, and for all of the markers with declining renal function, the association between mean glucose and the markers is continuously deteriorating. But as I said, we continue to recommend hemoglobin A1c as a method to monitor glucose. The key problem, as I mentioned, with hemoglobin A1c is the affection on red cell turnover in patients with chronic kidney disease, and therefore the usual bias is that because of anemia, you have too low hemoglobin A1c compared to what would be the mean glucose values. You can, in certain situations, also have elevated hemoglobin A1c, but that's much more rare a condition. In addition to the long-term monitoring of glucose, you can also say there's a need to the day-to-day monitoring of glucose measurements. And that's particularly if you are treated with interventions that induce hypoglycemia. So if you're treated with insulin, sulfonylurea, then the risk of hypoglycemia is higher. And then there is a, you can say, increased need for self-monitoring of blood glucose, either with a random glucose monitoring or with continuous glucose monitoring. Whereas if you are treated with medications like metformin, Sglt2 inhibitors, GLP-1 receptor agonists, and DPP-4 inhibitors, without a combination with glucose-lowering agents that provide hypoglycemia, then the need for self-monitoring of blood glucose is much less obvious. Then what about continuous glucose monitoring? Well, continuous glucose monitoring, it can be useful to establish not just mean glucose levels, but also what's called time in range, or what is the time where blood glucose measurements are in the range of 70 to 180 millimoles, or corresponding to 4 to 10 millimolars per liter. And the goal is that up to 70% is in this beneficial range, and that less than 4% are below this range in hypoglycemia. But in addition to establishing time in range, you can also use intermittent continuous glucose monitoring to establish a personal or individual correlation between hemoglobin A1c and mean glucose values, what is called a glucose management indicator. So that's a translator of the hemoglobin A1c in an individual when things are stable. Then you can use this information to translate hemoglobin A1c into a personal mean glucose level. And we have discussed in the guideline that in particularly if GFR is less than 30 and when hemoglobin A1c becomes less reliable, there's an increased use of continuous glucose monitoring could be advised, but there are also some difficulties in availability, particularly in type 2 diabetes in many places, which makes this perhaps more for the future than for current use in many places at least. This is from the ADA guideline showing that the target range or time in range where you are aiming for 70% being between 70 and 180. That's what you would like to be, not 47% as here, but up to 70% time in range. And you can get a lot more information with continuous glucose monitoring if that's available to you. So probably that's going to be the future. It's more used in type 1 diabetes. And I think for the future, what we would like to see is an indication or better knowledge about when does hemoglobin A1c work and when does it not work. We would like to develop better methods for continuous glucose monitoring in patients with diabetes and CKD, and perhaps develop alternative long-term biomarkers and test if, for instance, time in range is a useful metric to predict long-term outcome. At the recent American Diabetes Association, there were several posters and presentations looking at the association between time in range and renal outcome. So I'm sure this is something we'll see developing going forward. And we'd like to know also, as I said, can we use time in range as a metric? And also, what is the optimal glucose levels for kidney protection in our patients? That will be good to know for future target setting. And about target setting, then that's a balance where we need to, you could say, have a shared decision making with patient and healthcare providers about which target is appropriate. And that goes for patients with diabetes and chronic kidney disease as for any other patient with diabetes. And it's a balance between the risk for hypoglycemia and the adverse events of hyperglycemia. It's taking the individual situation into consideration, presence of cardiovascular disease or other comorbidities, life expectancy, and of course also the glucose lowering medication and the risk of hypoglycemia. And in the guideline we have developed in line with the balancing act seen for patients with diabetes without chronic kidney disease, a scheme where we have recommended that the target should be individually set based on shared decisions with the patient. And for some patients, a goal less than 6.5% in hemoglobin A1c may be appropriate, and for others, a higher target is important and fully valid. And the more advanced the kidney disease, the higher the target for hemoglobin A1c should be because of the risk of hypoglycemia and also other conditions with risk of hypoglycemia, comorbidities, life expectancy, unawareness of hypoglycemia, and so on would make a higher target more realistic to achieve. And then the treatment is, of course, also to be set into account. The risk for hypoglycemia is very important. That was about monitoring and targets. Tammy mentioned lifestyle factors that are very important, and we have addressed, for instance, diet, and said that diet should be individualized, taking personal needs into consideration. But in general, a diet high in vegetable, fruits, and whole grain, fibers, and legumes is recommended, and it should be low in processed meat and refined carbohydrates and sweetened beverages. We have also recommended that an active lifestyle is recommended, and at least 150 minutes per week of exercise is recommended, and particularly a sedentary behavior is advised against. And then in obese individuals, losing weight is recommended, particularly if GFR is above 30. We have tried to provide some guidance where you, based on the current level of activity, take into consideration what should be next step in either increasing physical activity after considering risk for falls or comorbidities, and then increasing physical activity gradually in order to achieve the 150 minutes of exercise weekly, which is also what is recommended in other populations. But data have demonstrated that in patients with chronic kidney disease in general, the physical activity is lower than in the background population. For pharmaceutical intervention, this is the ADA-Adhd Guideline, and I'll not go in detail with this, but just say that this is our guideline for diabetes and chronic kidney disease is pretty much in line with this guideline, but it's framed somewhat differently. Physical activity, nutrition, weight loss is the foundation. Then metformin is the starting therapy for all with type 2 diabetes, adjusted according to the level of kidney function. And then an Sglt2 inhibitor should be added to this, as you'll hear much more about from the next discussion. And also, if this is not sufficient to control glucose, well, then other agents like GLP-1 receptor agonists, DPP-4 inhibitors, insulins, and so on should be added according to patient preferences, comorbidities, level of renal function, and cost. The metformin treatment is usually a matter of debate in chronic kidney disease, so we developed this scheme where doses are adjusted according to level of GFR, so it might be reduced when you are in the range 45 to 60, and definitely if you are in the range of 30 to 45, and should be stopped if you are below 30. Additional glucose-lowering therapy is illustrated in this figure, where we take different comorbidities or characteristics into consideration, such as cardiovascular disease, hypoglycemia risk, or the need for weight loss, the costs, and the level of renal function. And together, these different aspects of characteristics can be useful in guiding what should be added to metformin and Sglt2 inhibitor. While we are dealing with diabetes and CKD, we should remember to screen for other complications, not only the kidney disease, but also eye disease, neuropathy, and general cardiovascular disease should be monitored carefully in our patients, so we should screen for that in all our patients. And then coming back to the point Tammy made about integrated healthcare systems and systems approach, well, it's important to provide education to patients and provide knowledge, beliefs, and skills and self-motivation, because the majority of the time the patient will be alone or with family and need to be able to manage diabetes in that situation and context. We have focused on the organization also and recommended that a multi-component integrated team-based care is really important. That will be with the patient in the center, with physicians and non-physicians like dietitians, nurses, and other healthcare providers that can help and facilitate education, structured evaluation of risk factors and complication status, and provide input to and set goals for the treatment going forward. And so a chronic care model has been proposed also in other settings where this multidisciplinary team is integrated in the care system to get an informed and activated patient and a proactive multidisciplinary team in order to improve outcome going forward for our patients. And I'll end by showing this slide saying that if you have multifactorial, multidisciplinary team with the patient in center, setting goals and evaluating targets, that's the best way to get coordinated care and good outcomes for our patients. And very important, and we should avoid the uncoordinated care. And also in many systems, if we can use electronic healthcare registers or systems to monitor screening and so on, that will provide better outcome and more control, regular screening for our patients. So to sum up, it's important, as we'll hear also in the next talk, about comprehensive care. We should monitor glucose with hemoglobin A1c, set individual targets. We should apply lifestyle interventions and glucose-lowering therapies. And we should think about how we organize care to do patient-centered decision-making and support throughout the care of patients with diabetes, with or without chronic kidney disease. Diet and exercise is important. We maintain hemoglobin A1c. and we should use metformin and Sglt2 inhibitor and then add additional glucose-lowering agents as needed. And self-management in a structured way is very important to achieve good goals. Finally, as Ian mentioned, the team that developed these guidelines, I'll thank everybody for their contributions. It has been a fantastic journey to develop these guidelines. And Ian showed the names, so I'll show a picture also of at least part of the group at one of the meetings we had where we discussed this guideline. So with this, thank you very much, and back to you, Ian, and sorry for the problems in the beginning.
Hello, everyone. Can you hear me?
Yep.
Okay, good. Well, thank you again for being here with us today, and I want to thank the ISN and KDIGO and Boehringer Ingelheim for their sponsorship. I will now be carrying on from where Peter left off and talk more specifically about the treatment for CKD and diabetes. Here are my disclosures. My objectives are to review the therapeutic approaches for treatment of CKD in the setting of diabetes, and in particular to recognize use of newer glucose-lowering agents to reduce both cardiovascular and chronic kidney disease risks, and to discuss the importance of comprehensive care of patients who have diabetes and CKD. So first up, I want to start with a definition because I think this is a source of great confusion about diabetic kidney disease versus diabetic nephropathy. In the context of the guidelines and most clinical trials, we're really talking about DKD because this is a clinical diagnosis based on albuminuria, low GFR, or both in the setting of diabetes. So it's really CKD and diabetes, but not a specific pathological phenotype. Diabetic nephropathy really was traditionally used to specify the classic glomerular lesions in diabetes. And now we know that there are many different lesions, and this is a source of active investigation. But at this point on the clinical side, in terms of testing therapies or implementing therapies, we really don't have a specific pathologic diagnosis. So remember that what we're going to be talking about is CKD and diabetes, recognizing that some of it is true diabetic nephropathy, but in some cases we're treating other forms of CKD in the setting of diabetes. So what happens to patients who have diabetic kidney disease or CKD and diabetes? In nephrology, our conventional focus has been progression to end-stage kidney disease, clearly a very important outcome for patients. But the truth is that only about 10% reach this endpoint. Most others will die of other causes without reaching end-stage kidney disease. About half are cardiovascular diseases, both atherosclerotic CVD and heart failure. But it's important to recognize that the second leading cause is infections, particularly pneumonia and sepsis. And I think in the current COVID-19 setting, this issue of infection may even become a bigger issue. So we need to think more broadly, not just about progression to kidney failure, but about reducing mortality. There are very low rates of CKD awareness detection, even in the current era. As you can see in the left panel, this is a very recent paper that just published online. It's not even out in print yet, where they evaluated awareness of CKD based on risk of end-stage kidney disease based on the KDIGO heat map. And even those who have high or very high risk of CKD, less than half are aware, only 40%, and this has not improved over the past 20 years. And part of awareness is detection. We can't be aware if we're not detecting disease. And so in a paper that we published examining 2 very large US healthcare systems with a cohort of about 2.6 million unique patients between the years 2006 and 17, we found that albuminuria or proteinuria was only measured in 15% of patients with diabetes and CKD, and in just 5% of patients with diabetes and no CKD. We get many more serum creatinine measurements so we can determine whether or not they have low GFR. And those creatinine measurements are rather unintentional because they come with all kinds of lab panels that we're ordering for various reasons. But albuminuria or proteinuria is much more likely to be intentional testing. And you can see, along with low awareness, how low, if you will, the intentional testing is in real-world clinical practice in the United States. So when we are aware and we have detected diabetes and CKD, as you heard in the previous discussion, we're really emphasizing comprehensive care, and it starts with the foundation of the basics: healthy lifestyle, risk factor management, and then in most patients, use of specific agents, conventionally renin-angiotensin system blockade, which I'll talk about a little bit, and then on now to Sglt2 inhibitors, and in many, and we've said some patients, antiplatelet therapies, especially recognizing, again, that important risk of cardiovascular death that we're trying to mitigate, as well as progression of CKD to end-stage kidney disease. I also want to emphasize that while I'll be mainly talking about drugs, there's no substitute for healthy lifestyle, particularly diet. And protein has been the main issue that has been so-called kidney specific. And what we have recommended is that a protein intake of 0.8 gram per kilo of idealized body weight per day for those with diabetes and non-dialysis CKD. This is the US recommended daily allowance. This is really not a low protein diet, but it's really avoiding excess protein, for which there is evidence in both preclinical models and some observational studies of harm, particularly if it's meat-based. We also emphasize that patients can get adequate proteins with plant-based diets. However, when patients go on to end-stage kidney disease and are treated by dialysis, we recommend a higher protein intake due to higher rates of catabolism and loss. The other important dietary recommendation is to reduce sodium intake to less than 2 grams per day. Which is important, particularly from the standpoint of blood pressure control. I won't belabor this slide, but in the guideline, we give some specific ideas about ways to reduce salt that would be achievable for most patients. Now, our conventional standard of care for CKD and diabetes has been to initiate an ACE inhibitor or an ARB. So we reiterate that in the guideline and then talk about particularly management of hyperkalemia or a greater than 30% increase in creatinine in order to try to maintain patients on these therapies. So reviewing concurrent drugs, moderating dietary intake, sodium bicarbonate if they have acidosis, and GI cation exchangers for potassium. And if a patient has a more than 30% increase in creatinine, think about what else might be going on with the patient, such as acute kidney injury, volume depletion, or something like bilateral renal artery stenosis. But trying to maintain those drugs, if at all possible, for their both cardiovascular and kidney protective effects. Now, this is a recommendation that's been in place for literally 2 decades. So how are we doing with just the basics? Well, excuse me. When we look back on the trials that drove this recommendation, again, nearly 20 years ago, whether we looked at renal or IDNT, they were similar populations of patients with macroalbuminuria and type 2 diabetes. There was a benefit with either losartan compared to placebo or irbesartan compared to calcium channel blocker amlodipine or placebo. They had similar risk reductions of 20% and 16%, so relatively modest, and so a large residual risk remained. And in fact, the residual risk at 48 months in both studies, the scales are slightly different, which is why the arrows are different sizes, but the absolute residual risk in both studies at 4 years of follow-up was still 40%. So you could see there is much risk left to address. But even with their modest effect on end-stage kidney disease or the composite, also doubling of serum creatinine, there was actually no effect on death. So really it was a doubling of serum creatinine or end-stage kidney disease endpoint. We really, despite the fact that we've known this for decades, we're still not implementing them very well. And in fact, again, this is from that same paper that looked at the care of patients with CKD, in this case, with or without diabetes, I'm showing here. we have seen an uptick in their use over time, but note that the absolute use is still remarkably low. And if we look at those who have diabetes with CKD and hypertension, perhaps the most clear indication to use an ACE or an ARB, we still did not exceed 25%, even in the most recent era of 2014 to 2017. But note that we're using NSAIDs and protein pump inhibitors in about a third of them. So we're doing harmful things, but we aren't doing good things. So there's a huge issue in terms of implementation that we, even today, are falling short on implementing appropriate therapies while giving harmful therapies. And I think this is an important prelude to the new therapies, because obviously we're going to have to change our approaches to implementation science and do a better job of delivering what the recommendations say. So there have been many therapies under study for diabetic kidney disease. Some of them are showing promise, some of them have been terminated, but what we're going to focus on in the guideline is Sglt2 inhibition and GLP-1 receptor agonists, because that's where we have the clinical trial data that allowed us to make recommendations regarding kidney disease and cardiovascular disease. So this is showing specifically trials of new diabetes drugs. So the previous slide showed new drugs for DKD. These are new glucose-lowering drugs. So you can see there's been remarkable numbers of studies conducted with these agents. And the ones that have really delivered for us are really the Sglt2 inhibitors and GLP-1 receptor agonists, initially based out of observations from the cardiovascular outcome trials that had kidney disease outcomes as secondary outcomes. So this is the USA Today headliner version, and I'll show you selected data that will back up this summary as well as the guidelines. So across the board, among the 3 agents that have been studied in large cardiovascular outcome trials, they reduced risk of so-called 3-point MACE, that's adverse atherosclerotic cardiovascular events. That's specifically, the 3-point is myocardial infarction, stroke, and cardiovascular death. And across the board, their largest effect is actually on reducing risk of heart failure. And at least 2 of the agent studies have also been shown to reduce cardiovascular deaths. So this is obviously a major breakthrough for type 2 diabetes in general, but in particular for the CKD population who are at such high risk of these cardiovascular events. But across the board, they also decreased macroalbuminuria, decline in GFR, and end-stage kidney disease endpoints. And notably, the benefits on the heart and the kidney, as well as their safety, have been demonstrated in patients with pre-existing CKD. The only trial to date that has been published using an Sglt2 inhibitor in a population with DKD was the Credence trial. This was a trial of people with macroalbuminuria and GFR between 30 and 60 ml per minute per 1.73 meters squared. There was 99.9% coverage with an ACE or an ARB, so they did deliver the recommended care to this group of patients. And this is showing the hazard ratio for use of canagliflozin versus placebo. So a 30% risk reduction, highly statistically significant. And notably, this trial was stopped early for overwhelming efficacy, the first time in the history of nephrology that we've had a trial stopped for good news. And also, the drug received FDA approval for treatment of CKD and diabetes last fall. And it also included an indication to prevent CVD death, as well as the kidney disease endpoints, which is another first. It's the first drug in the field of nephrology that not only has an approval to prevent end-stage kidney disease or progression of kidney disease along with death. These are the primary outcomes by GFR and albuminuria. So whether they had albuminuria above or below 1,000 milligram per gram, and at various strata of eGFR, the benefits held, the interaction p-values are not significant, meaning that the effects are similar across these subgroups. So whether they had higher or lower GFR within the range studied or higher or lower albuminuria within the range studied, the effects held. Also in a meta-analysis, which I'm not going to take the time to show you, that looked at even lower levels of albuminuria, actually down to the micro level in the cardiovascular outcome trials, the results were also similar. This is from another meta-analysis combining the CV outcome trials that tested SGLT2s along with Credence, where there was comparable data, looking at various versions of the kidney disease endpoints. We don't need to go through each of them except to say no matter how you want to define important kidney disease endpoints or progression, there was benefit across the board in the CV outcome trials as well as in Credence. Also, a theoretical concern had been that these agents might increase risk of acute kidney injury, and whether you look at Credence as a standalone or Credence in a meta-analysis with the CV outcome trials, we see actually there's a reduction in risk of AKI, and the magnitude of the effect is the same. So the relative risk at 0.75 means a 25% risk reduction. So not only are they safe against AKI, they protect against AKI. There are many potential mechanisms. One of the leading mechanisms is reduction of hyperfiltration. This is from the IMPA-REG trial, where, again, kidney disease was a secondary outcome, and from Credence, where it was a primary outcome. But when we look at GFR trajectories over time, either in the IMPA-REG group starting at a higher GFR of about 75, we see the abrupt drop in GFR initially, followed by stabilization with progressive decline in the placebo group. And even in the more advanced group in Credence, who started at a baseline GFR of about 56, we see the same pattern of initial reduction and stabilization, which is most consistent with a hemodynamic effect. Certainly there may be other effects, but this is the one that I think is most clear and that we can use from a therapeutic standpoint as we think about clinical implementation. And just a very brief review to remind everybody that early in diabetes, and even later in diabetes with remnant nephrons, there is glomerular hyperfiltration with a relatively dilated, inflowing or afferent and relatively constricted efferent. When there's diabetes, there's high pressure in the glomerulus, increased filtration of glucose, more reabsorption of glucose in the proximal tubule by SGLT2 transporters, resulting in less distal delivery, not only of glucose, but of sodium, since this is a sodium-requiring process. When there's decreased distal delivery to this specialized area in the distal convoluted tubule, the so-called macula densa, there's less generation of adenosine by use of sodium-potassium ATPase for sodium uptake. And adenosine is very important because in a paracrine manner, notice this sits right next to the inflowing artery. The generated adenosine combined the adenosine 1 receptor here, where it clamps down the artery, a relative vasoconstriction. So in its absence, there's vasodilation. When we give an Sglt2 inhibitor, not only do we increase distal delivery of glucose, but of sodium, and we restore tubuloglomerular feedback, in a sense, clamping down this inflowing artery. And combined with an ACE and ARB, or an ARB, which mainly act on the downstream artery to dilate this, we reduce glomerular pressure. So that is the leading hypothesis. And we don't have time to go into other mechanisms. There probably are others, but this is probably a very important one, that SGLT2 inhibitors, especially when combined with an ACE or an ARB, are very effective at normalizing glomerular pressure in a way that produces better outcomes. The other very important observation from Credence was about the cardiovascular outcomes, and it was the first study that included people who had not had a prior cardiovascular event, although many had, so there was a secondary prevention cohort as well. And whether the outcome was cardiovascular death and heart failure, shown in the top panel, or MACE events, atherosclerotic events, in the lower panel, both primary and secondary prevention cohorts with CKD benefited. And this was the first time that these agents were shown to be beneficial in any population for primary prevention of atherosclerotic CVD. So again, the crosstalk, if you will, between the kidney and heart is likely very complicated. Certainly with increased natriuresis and diuresis and control of intravascular volume and blood pressure, this will produce favorable effects such as reduction in LV wall stress. But there are also other effects that again, are beyond the scope today, but they increase oxygen delivery by increasing red cell mass through increased erythropoietin production by the kidney. They also produce a relative ketosis, which is related to higher glucagon, as well as to increased free fatty acids, and beta-hydroxybutyrate appears to be a preferred fuel for the myocardium. And there may even be an off-target effect of the drugs to reduce sodium-hydrogen exchange of the myocardium, which all of which can culminate in less oxidative stress as well. So we're still unraveling this because the science is almost being retrofitted to the clinical observations, but suffice it to say that these drugs are very effective not only in reducing progression of kidney disease, but through renal as well as direct cardiac mechanisms are also highly protective of the heart. So now with regard to GLP-1 receptor agonists, they too were studied in CV outcome trials originally for safety. And across the board, the major effect of these drugs are to reduce atherosclerotic events. And two of them, liraglutide and semaglutide, have also been shown to reduce CVD death. But in the secondary renal outcomes, they do reduce macroalbuminuria, and they reduce GFR decline from early to later stages of CKD, and two agents, liraglutide and dulaglutide, have been shown to do this. And similar to the SGLT2s, the cardiovascular and kidney disease benefits and safety have been demonstrated even in patients with pre-existing CKD. So this is from a meta-analysis of the GLP-1 receptor agonist, the cardiovascular outcome trials, looking at the secondary composite kidney outcome that included macroalbuminuria or simply worsening of kidney function. And you can see across the board a relative or a risk reduction of about 17%, slightly less when the macroalbuminuria outcome is removed. But remember, these were patients selected for cardiovascular disease, so they had, in general, well-preserved kidney function. So the albuminuria outcome would be easier to show with these agents in this population. The one study that has been done in patients with moderate to severe CKD, you can see a mean GFR of 35 and an active comparator study for glycemic control with insulin. Here are the main secondary endpoints were also related to kidney disease. This is eGFR in the insulin group, a progressive decline over 1 year with stabilization in the dulaglutide group. Here is a bar graph just simply showing the amount of GFR decline at 26 and 52 weeks in the insulin group, about minus 3.3, with a non-significant reduction in the dulaglutide groups, a highly significant difference from insulin between insulin and these groups over 1 year. So preservation of GFR, even in patients who start with a GFR of 35. This is data that has been presented publicly, so I will show it. The paper is winding its way through publication, but these are in the public domain. So I will show you the effect on an exploratory but pre-specified outcome, which was 40% GFR decline in stage kidney disease or death, but it truncated to these two outcomes because we didn't have kidney disease deaths in the trial. And you can see that there was a reduction in the overall number of events by more than half in the high-dose dulaglutide group. And in the group with macroalbuminuria in a time-to-event analysis, here's the highest dose dulaglutide group in blue versus either a lower dose or insulin, and the hazard ratio was 0.25, so 75% risk reduction. This is exploratory data, so certainly not confirmatory, but it has, between the CV outcome trials and Award 7, has led to now the FLOW trial, which is actually testing semaglutide in a design comparable to Credence to learn whether or not it actually is beneficial to prevent these events in patients with CKD. Again, we are short on time, so I'm not going to go through the details, but there is biological plausibility, very different mechanism than SGLT2, probably related to an anti-inflammatory effect and also a diuretic effect and indirect effects, for example, on blood pressure lowering, which we also see with the SGLT2s. So back to the guidelines. This is a slide showing the summary of benefits and harms based on the available clinical trials of SGLT2 inhibitors, GLP-1 receptor agonists, and DPP-4 inhibitors. And basically, our headliners today are SGLT2 inhibitors. Although they have a a modest effect on atherosclerotic events, a major effect on heart failure, and then major effects on kidney disease. There are some side effects, again, outside of the scope of what I can discuss today, but these are things to be aware of, particularly genital mycotic yeast infections, diabetic ketoacidosis, and amputations. In the guideline, we go through mitigation strategies, and if we have time for questions, I'd be happy to address those. With regard to GLP-1 receptor agonists, also a reduction in atherosclerotic events, neutral effect on heart failure, less effect on albuminuria and GFR loss, but still can be very valuable as an adjunctive therapy for glucose lowering, particularly in patients with low GFR. DPP-4 inhibitors really have not delivered, other than for their effect on glucose lowering, really no significant effects other than a mild reduction in albuminuria. So back to a slide that Peter showed, when we think about how to implement anti-hyperglycemic therapies in patients with diabetes and CKD, yes, they're for glucose lowering, but they're also for organ protection. When we say organ protection, we mean both kidney and heart. Peter talked to you about the importance of using metformin as a base along with Sglt2 inhibitors unless they can't be given for the reasons that he discussed, and that GLP-1 receptor agonists are a preferred add-on therapy, particularly to get to glycemic goals, and they don't have an increased risk of hypoglycemia like some of the other agents such as insulin or TZDs. And the emerging data suggests that we are at least hopeful in testing whether or not they could potentially provide kidney protection on top of the other established therapies, ACE, ARB, SGLT2, GLP-1s. So again, my take-homes would be the long-standing standard of care, ACE or ARB use, is underutilized, and I think now is the time to get a reset on doing better with regard to standard therapy. The new standard is adding an SGLT2 inhibitor for patients who have a GFR above 30. And here, the main implication will be for organ protection, both heart and kidney, although they may add a bit for glucose lowering, but their effects on glucose lowering are much reduced once GFR is below 60. The GLP-1 receptor agonists are effective anti-hyperglycemic agents that reduce risk of atherosclerotic CVD in patients with and without CKD, and they may also lower risk of albuminuria and GFR decline. And then, as Peter emphasized, self-management, education, and team-based care are recommended and really should be part of the comprehensive package delivered for patients with diabetes and CKD. And with that, I thank you for your attention.
Thank you very much, Kathy. It's Ian here, and we are at the time, but maybe we can, there are excellent questions, and I think we could go a few minutes over to address a few of those. So if the presenters could turn their cameras and audio back on, we'll very quickly go to those. Peter, I'll give the first one to you. There's a question about the combination of SGLT2 and GLP-1 receptor agonists. Can you comment on the science there? Is there evidence of benefit, safety, and cost?
Well, cost is, as you say, an issue to start backwards. And for benefits, there are studies showing benefits on short term for glucose, blood pressure, and weight, but there are no long-term data on this combination. So it's recommended in many guidelines, including ADA, EASD, and in our guidelines, because of the hoped or the scientific evidence or suggestion that it could be beneficial, but we lack outcome data.
Great, thank you. Kathy, perhaps for you, a question about whether albuminuria figures into the prescribing recommendation for SGLT2 inhibitors.
Ian, that's a very good question. And depending on the guideline group, it varies. So in KDIGO, we're recommending irrespective of albuminuria. But for example, in the ADA guidelines, they recommend them for people with albuminuria, either micro or macro, with a stronger recommendation in macro. So I think, though, that if you look at the cardiovascular outcome trials, for context, where the agents were equally kidney protective, irrespective of even low levels of albuminuria, I think we made the right call in KDIGO, and I think that they should be utilized even in patients without albuminuria.
Yeah, and I might add as well, part of the rationale is, as you noted, Kathy, their cardiovascular outcomes and kidney outcomes are both important, as are others in people with diabetes and CKD.
Yep.
And regardless of these subtypes of CKD, there were benefits in both. Peter, maybe back to you for a question about the initial decline in eGFR with Sglt2 inhibitors. In particular, is a problem when you combine or add to RAS blockers, and is there a decline that's of concern?
I mean, we have for RAS blocking agents said you should be careful if you have a drop in eGFR when you start off more than 25 to 30%. There's no data really to recommend a threshold where you should be concerned for Sglt2 inhibitors. We see this initial drop, as Kathy demonstrated, and we have not been able to set a cutoff for this. But of course, it's normal to have an initial drop and then a stabilization.
Great. And Kathy, perhaps back to you for a question about loop diuretics and interaction of these drugs with loop diuretics.
Sure. Well, normally we don't recommend an adjustment in the diuretics because more commonly than not, we're fighting fluid retention between their heart failure and their CKD. So often they're a very welcome adjunct to loop diuretics. However, in patients where there's a concern about volume depletion or low blood pressure, I think that has to be an individual decision, and it would certainly not be unreasonable in a person like that. So in general, no, but use your own decision making, and back to what Tammy said, work with the patient, look at them as an individual, and if there's somebody who you think would be at risk of volume depletion, then it's not unreasonable to consider diuretic dose reduction. But remember, more commonly than not, we have the opposite problem, and usually it's a good thing to have the combination.
And Peter, I think the last question, for the sake of time, what about Sglt2 inhibitors in patients who have a kidney transplant?
That's a very good question. There's not much data. There's a few number of studies suggesting that they work and are beneficial and safe, but it's very small studies. So we would really like to see more studies. In general, dialysis and transplanted patients, there are not that many data in studies. So yeah, unfortunately, we will have to do more studies in these populations.
Great. So I think we should stop there. We're about 5 minutes over. I'd like to thank all three presenters, Tammy, Peter, and Kathy, for wonderful presentations. The whole work group, who has devoted a lot of time and energy to thinking through this and translating evidence to guidelines. The evidence review team, who synthesized the data available on which these guidelines are based. The KDIGO leadership and staff for supporting this guideline. Boehringer, Ingelheim, and Lilly, as well as the ISN for showcasing this webinar, and all of the webinar attendees for your dedication to treating people with diabetes and CKD. And I'll note again that the full guideline, we hope, will be published this summer. There were more great questions raised in the discussion here. We could not get to them all. The guideline does include extensive guidance for implementation. Many of the practical points that were addressed are covered in the guideline and the executive summary. So I encourage you to look at that when it comes out very soon. So at this point, again, thank you to all of you, and we'll conclude this webinar. Take care.